Good day, everyone. On behalf of Cambridge Health Tech Institute's Global Web Symposia Series and our sponsor, Biomodels LLC, I'd like to welcome you to Preclinical Animal Models in Cancer Supportive Care. My name is Elizabeth Lamb, and I'm the host and moderator for today's event. Now I'd like to introduce our speakers for today. First is Dr. Gregory D. Ling, PhD, Chief Operating Officer for Biomodels. Our second presenter is Dr. Jesus Mena, PhD, Scientist 2 with Biomodels. And our third presenter is Dr. Benjamin G. Cuffo, PhD, Principal Scientist with Biomodels. So welcome to you all. Dr. Ling, the presenter ball is yours.
Great. Thank you, Elizabeth, and thank you, everybody, for attending today's webinar. To start today, we're going to talk about, as Elizabeth mentioned, preclinical animal models in cancer supportive care. And I'm going to start with just a little Biomodels itself. So Biomodels, as you may or may not know, is a preclinical contract research organization. We're located in Watertown, so just outside of Boston in the Cambridge area. We were founded in 1997 out of our Chief Scientific Officer's lab at the Brigham and Women's Hospital out of Harvard. And our focus is on highly translational models of human diseases. And we look at a variety of conditions for a wide variety of clients, ranging from academics to large pharmaceutical companies. Internally, we have therapeutic expertise within inflammation and autoimmunity, microbiome, oncology, pulmonary disease, fibrosis, cardiovascular disease, metabolic disorders, neurology, and psychiatric disorders, as well as cancer supportive care, which will be the focus of today's talk. One of our big success stories that we're really proud of is that we've facilitated over 50-plus compounds in our 20-plus years of existence that have gone from test agents here and into patients. So the objectives for today's talk is to basically understand what regimen-related toxicities are and how cancer supportive care is used. So we're going to go through some background, some current treatment strategies, and then we're going to kind of finish up with an overview of a number of animal models that we routinely conduct here at Biomodels for these indications. A brief summary of that is, oral mucositis, radiation dermatitis, radiation proctitis, chemotherapy-induced diarrhea, which is also called GI mucositis. And then we're going to have a discussion about how these cancer supportive care models are used in the context of tumor treatment. So what are regimen-related toxicities? So these toxicities or side effects occur in basically healthy tissue that's associated with cancer therapy. They're often caused by radiation therapy, chemotherapy, and the use of targeted therapies or immunotherapies, which are growing in use, and the toxicities from these are growing in our understanding. So radiation toxicities are often based on the tumor location. That's given the way that radiation is targeted to the tumor site, whereas chemotherapy and targeted therapy toxicities tend to be a little bit more diffuse in nature, given the systemic nature of the therapy. Ultimately, any of these treatment modalities can cause the following. And these are just a few of the side effects that are seen, but the ones that we'll be focusing on today. Dermatitis, which is obviously a skin condition, which ranges from mild skin redness to overt ulceration. Oral mucositis, which is most common in patients being treated for head and neck cancer, but can occur in multiple other treatment modalities, ranges from mild redness in the mouth to severe ulceration. GI mucositis or chemotherapy-induced diarrhea is very common with systemic therapies and or with GI-focused radiation, and that can range from mild discomfort to severe ulceration and bloody diarrhea. And radiation-induced proctitis, which is common with any pelvic radiation, so including gynecological malignancies and prostate cancer. And that's where symptoms in the lower GI will range from mild discomfort to, again, severe ulceration and bleeding, and even fecal incontinence. So why are these of concern? Obviously, the main goal with cancer therapy is to eliminate or control the tumor growth. These toxicities can have effects on that. One of the biggest one is being dose-limiting. So these dose-limiting toxicities can basically cause a limited dosage of radiation or chemotherapy. They can also cause breaks in treatment. So obviously, a cancer therapy is intended to occur over a specific duration to have its best outcome. Now, cancer therapies may be halted or delayed while people recover from these toxicities. Additionally, there's the impact of unscheduled hospitalizations. This is not only good for the not good for the patients, but also increases the cost of cancer therapy in general. And finally, quality of life. Patients with these toxicities are miserable and actually may decide to halt therapy simply based on the side effects of their therapy. Ultimately, all of these can reduce the likelihood of a positive tumor outcome and or survival, as well as increasing the cost of cancer treatment. So now, what is cancer supportive care? These are essentially treatment strategies that are employed to prevent or limit the effects of these regimen-related toxicities. Ultimately, the goal of cancer supportive care is to increase the likelihood of positive outcomes in cancer treatment by allowing for higher doses of radiation or chemotherapy, which will increase the likelihood of tumor kill, allowing for on-time completion of cancer treatment protocols, reducing the need for unscheduled hospitalizations and outpatient care, and ensure that patients' quality of life is impacted as little as possible during cancer treatment. So as we think about cancer supportive care and regimen-related toxicities in the drug development setting, these are just some important points that we think that everybody should be aware of. These toxicities are not simply nonspecific cell death, meaning that they are more focused to specific areas and aren't just generally occurring nonspecifically across the body. They do not occur as isolated events, meaning that toxicities often cluster and that patients who may have one toxicity are more likely to exhibit others. The risk is multifactorial, predictable, and quantifiable, meaning that we can identify patients at risk. The response of normal cells and tumor cells to radiation and chemotherapy is not the same, meaning that we need to understand how these therapies will impact both normal and tumor tissue. And ultimately, we know that pharmacologic toxicity prevention at the mechanistic level can be done without modifying the tumor kill, essentially meaning that we can control the side effects, these regimen-related toxicity side effects, without impacting the ability of cancer agents to kill tumors. So I'm going to go into a little bit of a background on oral mucositis, and this will be the first regimen-related toxicity that we talk about today. Now, oral mucositis is a common and painful dose-limiting toxicity associated with radiation therapy and or chemotherapy. It's characterized by the breakdown of the oral mucosa, resulting in ulcerative lesions. You can see this here on the base of this patient's tongue. This is all severe ulceration. That ulceration can go down as deep as the muscle layers. These lesions can also be a portal of entry for bacteria, which can lead to sepsis or bacteremia, and thus increasing the risk to these patients. As I mentioned, this is fairly common, and it occurs in almost 40% of patients receiving cancer therapy, given that we have somewhere between 1.4 and 1.7 new cancer cases, 1.4 and 1.7 million new cancer cases in the U.S. for 2019. That'll mean over 500,000 patients will develop mucositis annually. The duration of this can vary depending on the treatment regimens. It can be anywhere from 2 to 10 or more weeks, depending on what is being done. And importantly, with cycled chemotherapy, which is obviously not including radiation, mucositis can reoccur during every chemotherapy cycle, meaning these patients will basically develop and recover numerous times. So why is mucositis a target for drug development? I think one of the key things to look at is the pharmacoeconomics of what mucositis is and how it impacts our healthcare system and patients. Obviously, on the patient front, it results in unplanned office and emergency room visits. Patients can be admitted into the hospital for fluid support, pain control, or infection management. And also, there are interventional approaches that sometimes have to occur given the severity of ulceration. So patients may have to go on a G-tube, and G-tubes also come with some side effects and risks. The incremental cost that's been shown for patients with mucositis has been somewhere around $18,000 per patient with solid tumors, and then in transplant populations, upwards of $40,000 a patient. Based on the number of patients that are coming down with mucositis annually, that gives us an approximate market size of $1.5 billion a year. So certainly not a huge market, but a sizable market when you think about looking at drugs and drug sales. So current treatment strategies. These are pretty limited. Pelafermin was approved a number of years ago. That's only in the transplant population. Currently, there are no approved drugs or biologics for solid tumors, including that of head and neck cancer, where much more than 50% of the patients being treated for that will develop mucositis. There are a number of devices that are out there, including magic mouthwash, which is basically a concoction made at hospitals that can include varying different agents, certainly not regulated in any way, shape, or form. But the devices that are currently used are focused on barrier function and basically will develop a artificial barrier to reduce pain and possibly reduce the risk of infection, but very rarely have much effect on duration or course of mucositis itself. Those include Gelclair, Mugard, Episil, and Captisol. And I'm not intending to go through this slide in any detail, but ultimately what we want to show is the biology of mucositis, and most of the toxicities that we'll talk about today, which are all pretty similar, is extremely complex, and it leaves us many places to potentially target for drugs. Anywhere from the induction phases where we're giving the radiation or chemotherapy and you're getting side effects of reactive oxygen species and inflammatory responses, all the way out through the healing process and barrier function during ulceration. So many different areas where drug development can focus. So in mucositis specifically, the goal of novel therapies is to maintain the mucosal integrity. So basically eliminate or control ulceration, as the ulceration is really the driving factor of hospitalization and dose-limiting toxicities when it comes to mucositis. Currently, there's been a pretty limited clinical success and therefore a big need for new novel therapies. With that, there are quite a few drugs currently in the clinic that are intended to either prevent, accelerate the healing, or provide relief from a pain associated with mucositis. This table at the bottom here shows some of the active clinical trials in the space and where they stand. Obviously, we're looking at very different routes of administration. The one advantage of oral mucositis is that it's a very confined compartment, so topical therapies or oral rinses are a common approach. But you'll see that a lot of the drugs that are more advanced, phase 2, phase 3, are actually systemic therapies. Speaking back to the kind of broader effects of radiation and chemotherapy on the body and how the systemic therapy would make sense in that sense. So as we talk about mucositis, and now we're going to kind of switch gears a little bit and talk about animal models. And what we have here is kind of how we describe the perfect animal model, whether this is in cancer supportive care or any other indication. Ultimately, these models must replicate the clinical condition. The endpoints need to be translatable to those used in the clinic and easily understood. The biology needs to be the same as in humans so that they can respond to similar targets. The model also must be cost-effective and provide actionable information to advance products in the market. So at Biomodels, we conduct a variety of different approaches for modeling of oral mucositis. These range from acute radiation paradigms where we're giving a single bolus of radiation. In the hamster model, that's 40 gray, single dose. To fractionated radiation models where we administer multiple doses of radiation over the course of a couple weeks to more closely reflect what occurs in the clinic. We also have models where we can use chemotherapy as a radiation sensitizer in the hamster. And then we also do models in rats and mice that will allow us to more closely evaluate mechanism of action, just kind of given the availability of reagents and testing protocols that are more common in mice and rats than are in hamsters. So the hamster model is by far and away the most common model that's used to evaluate potential therapies for mucositis. This model was actually developed by our CSO, Dr. Steve Sonis, a number of years ago, and was kind of the founding platform of Biomodels. So this model is run either, as I mentioned, in an acute dose setting or a fractionated dose setting of radiation. In the acute setting, we're using a single dose of 40 gray. In the fractionated setting, we're using 8 doses of 7.5 gray for a total of 60 gray. Obviously, the fractionated dosing is more reflective of what occurs in the clinic with patients that undergo small fractionated doses for 5 to 6 weeks typically. Whereas the acute model is more often used as a screening tool. It's shorter in duration, less expensive to conduct, and still provides very actionable data. These studies vary from 4 weeks to 5 weeks, possibly 6 weeks in duration, depending on how we run the protocols. And the primary endpoint, as it is in patients, is mucositis severity. You can also do histopathology, but ultimately what we want to see in these models is that the compounds will control ulceration. So the severity of these ulceration is evaluated in the models that we conduct by blinded observers, and we basically score it on a scale that's very similar to what is done in patients for the evaluation of clinical data. So what we see on the right here are 2 examples of what the hamster cheek pouch looks like in a naive setting, as well as in ulcerative mucositis. So we can see that a normal cheek pouch is very thin, transparent, not inflamed, whereas in the ulcerative condition, you see extensive ulceration, inflammation, appearance of fibrosis, and it's a very obvious endpoint. And I think that's one of the big advantages of this model is that we can, that the endpoints are not trivial and but are very easy to interpret. Ulceration is something that is very obvious to any observer when it's observed. So I think one of the key things that we want to talk about when we talk about the hamster models is that how the human model, or how the human condition and how the hamster model reflect one another. As we can see here, these graphs will show mucositis severity with scores of 3, meaning ulcerative mucositis, as kind of the main point. While the axes are very different in duration, here we're looking at a scale of weeks versus a scale of a couple weeks, we can see the trajectory is pretty similar. So as radiation dose increases, the extent of ulceration increases. After radiation ceases, there is a resolution phase. The hamster model is very similar to that, seeing that this is after an acute radiation dose of 40 gray. We see a very, very reproducible curve where animals will develop ulceration by day 16 to 18 and slowly resolve thereafter. This data here is from a manuscript that we contributed to a few years ago, and this is very typical data that we see with compounds that are showing efficacy in the model, whereas you'll see basically an accelerated healing profile or actually inhibition of ulceration. So I think that's one of the big advantages of this hamster model is that there is a lot of preclinical data out there and available. So if you were to run a study in one of these models, there are a lot of studies that we've conducted at Biomodels that have been published, and the consistency of the model itself and the amount of data that's available allows for direct comparison of the results of your drug to drugs that are currently in clinical trials to get a sense of how you compare in terms of activity. This top figure is from a manuscript that we co-authored with Cyclone Therapeutics a number of years ago, and the bottom one is the one that we published with Actogenics. But ultimately what you're looking at here are percentage days of ulceration, and this is very similar to how it's presented in clinical trial data as well. And what we're looking at is studies that were done potentially a couple years apart, but ulceration being at around 50% with treatment modalities causing the reduction of ulceration by anywhere from 30 to 50% over baseline. And ultimately, as we mentioned earlier, the importance of the animal model in showing translational outcomes. This data below here is from a manuscript that was published by Sologenics just a couple of years ago, looking at the effects of their compounds in both the hamster model of mucositis as well as in their clinical trial. What's very interesting here is that if we look at duration of mucositis from what we showed in the hamster studies, being about a 46% reduction, what they're actually seeing in humans is about a 49% reduction in duration. So what we can take from this is not only is the model itself consistent, but the data that we're getting from these models is translational to the clinic. So we can be really confident in the data that we're obtaining from these. So that's about all I'm going to say for today. I'm going to pass this over to Dr. Jesus Mena now, who's going to talk a little bit about radiation, proctitis, dermatitis, and GI mucositis.
Thanks, Greg. So I'm going to jump right in here and discuss radiation-induced proctitis. Just briefly, for those who may not know, radiation-induced proctitis is a common complication associated with radiation directed to the abdomen and or pelvis in the treatment of colon, rectum, prostate, or cervical malignancies. It can occur in up to 75% of patients receiving targeted radiation therapy, resulting in approximately 400,000 new cases annually. Acute proctitis symptoms first present within 2 weeks of radiation therapy and can persist for up to 3 months, whereas delayed or late proctitis is a chronic disease that may continue for decades. Symptoms include rectal bleeding, diarrhea or discharge of mucus, fibrosis, ischemia, and necrosis of the bowel tissue, which may require surgical intervention. Diagnosis is typically performed via colonoscopy, and that's mainly to exclude the possibility of any other underlying pathology. Now, drug development in this space is fairly limited. Current treatment strategies are adapted mainly from those used in irritable bowel disorder, such as 5-ASA, steroids, sucralfate, and metronidazole. And endoscopic therapies to control bleeding, such as argon plasma coagulation, have also been developed. But there still very much exists a large unmet clinical need, and there's a limited pipeline of novel therapies. The mechanisms of proctitis are similar to those of other epithelial toxicities. Greg briefly mentioned some of these as they relate to oral mucositis, and you'll see that these also apply for radiation-induced dermatitis, which I'll discuss briefly in a few minutes. But essentially, they impact reactive oxygen species generation, lipid peroxidation, and NF-kappa B, to name just a few. The similar mechanisms in these indications provide additional opportunities for drug development, and that the drug therapies that are in development can act on multiple indications. Unique vascular changes resulting in chronic bleeding and fibrosis that are seen in some of these more challenging chronic symptoms also provide additional therapeutic targets. So, like with the oral mucositis model, we can perform radiation-induced proctitis here at Biomodels by utilizing 2 different paradigms, an acute or a fractionated paradigm. The differences between the two is that the acute radiation paradigm utilizes 1 dose of 20 gray, administered generally at around day 0. And it leads to a relatively quick onset of disease, where peak disease occurs at around day 7. And then spontaneous healing occurs shortly thereafter. With the fractionated radiation proctitis model, you can see that we provide 8 fractions of radiation, and we can increase the dosage of radiation to provide more severe levels of proctitis. Here again in the timeline, you can see that the cumulative dose of 32 gray leads to small disease severity, and increasing that in a dose-dependent manner leads to increases in that. Also different between the 2 models is that the acute model is much shorter in duration than the fractionated model, and so that provides some difference as well. But importantly, the human condition, as shown here, is fairly well replicated in the rodent condition, as shown here. And one final point, as obviously you've noticed, these are all based on rodent video endoscopy, and that's another particularly important endpoint that we use here. It provides us the ability to track disease progression in life rather than just depending on histological endpoints at the end of the study. Quickly switching gears, I'm just going to briefly discuss radiation dermatitis, and this is injury to the skin that results as patients are exposed to ionizing radiation for treatments in cutaneous neoplasms, head and neck, and breast cancers. The prevalence is, or the rate of incidence rather, occurs in 85% of patients and ranges in severity from mild erythema to moist desquamation and ulceration. There's a large impact on patients' quality of life, and it can be dose limiting. The economic burden, not only to the patient, but also to the healthcare system, is therefore increased as a result of that. This table just shows the acute skin effects that result as the dose of radiation is increased. So you can see that lower doses of irradiation lead to milder acute skin effects such as dry desquamation and moist desquamation and ulceration. And then very high doses of radiation can lead to much more severe skin effects such as fibrosis and telangiectasia. Also, the onset of disease is rather quick with cumulative doses that are low, whereas cumulative doses that are high, the onset of disease can be delayed, not resulting in as long, it could take up to 6 months to a year after radiation for some of these more severe skin effects to present. Our animal model for radiation dermatitis is fairly straightforward. The hair is removed from the back of the animals using an electric shaver several days prior to irradiation, and that area is then pinned such that that's the only area that receives radiation. The rest of the animal is protected by a lead shield. The animals are irradiated with an X-ray source at a rate of 1.5 gray per minute, and we can track the doses of radiation by using thermoluminescent dosimeters. Like with oral mucositis and proctitis, we can employ two different modalities, an acute radiation approach or a fractionated radiation approach. And for acute radiation, we use a dose of 30 gray, and then we can evaluate dermatitis scores starting on day 4 and continuing to the end of the study every 2 days. And with the fractionated radiation, we use 6 fractions of radiation, providing us with the ability to change the dose of radiation, and then we can evaluate starting on day 6 until day 36. The dermatitis scoring scale is based on well-established clinical scoring scales such as CTCAE and RTOG, and it's a 5-point scale which includes a full spectrum of disease severities that closely mimics what's seen in patients. A score of 0 represents normal tissue, as shown in these photomicrographs, where a score of 5 represents frank and active ulceration of tissue. For us, a clinically meaningful signal is defined as improving the symptoms of desquamation and erythema, such as reducing the kinetics and severity of disease and or reducing the number of days with high dermatitis scores. Again, just showing here the sort of trajectory and the differences between the two approaches. So with the acute, you see a very rapid onset of disease peaking at around day 12 and then gradual resolution towards the end of the study. And with fractionated model, again, we can tailor this for sort of a dose-dependent effect based on the cumulative radiation dose used, where lower cumulative doses of radiation lead to lower incidence or lower magnitude of disease, while higher doses of radiation lead to higher peak disease. And again, there's a bit of a delay in onset in the fractionated versus in the acute, and resolution takes a little bit longer than in the acute model as well. This is just showing just how well the histological endpoint correlates to the in-life dermatitis scoring. So a non-irradiated animal here has very healthy tissue as demonstrated by histological assessment. And as the dosage of radiation is increased, cumulatively, you start to see much more damage to the underlying tissue from a histological standpoint. So you see more thickening of the epidermal layer, inflammation, and even the influx of immune cells to the injured area. Just as an example of a paper that we helped collaborate on that demonstrated the utility of this model for testing the efficacy of an experimental compound, we helped Reata test their compound RTA-408, and I'm just very quickly going to demonstrate this data here. And so essentially what it shows is that animals in the vehicle group by day 16, which represents peak dermatitis, had very severe dermatitis damage, but increasing concentrations of RTA-408 were able to successfully mitigate this damage. And this was particularly long-lasting, as by day 30, we started to actually see that the Reata 408 highest concentration, the animals were even demonstrating regrowth of the hair that was damaged, the follicles and things like that. And again, histologically, you can see that that result was also supported. And as you can see here, for dermatitis scoring, increasing concentrations of Reata 408 led to a mitigation of disease severity. When just looking at scores greater than or equal to 3, which represent severe dermatitis, the highest concentration of RTA-408 had a particularly profound effect in ameliorating that. And this sum score just represents the scoring that's performed by our histopathologist, board-certified pathologist who scores these images blind and generates a sort of a scoring based on different readouts. And again, it just demonstrates that the Reata 408, the highest concentration, has a positive effect in this example. Finally, the last model that I want to discuss today is our GI mucositis or chemotherapy-induced diarrhea model. CID is a common complication associated with chemotherapy treatment, and the incidence can occur in up to 50 to 80% of treated patients, especially those treated with 5-fluorouracil or some combination of therapies of irinotecan and fluoropyrimidine. It can lead to depletion of fluids and electrolytes, malnutrition, dehydration, hospitalization, and the diarrhea can interfere with and detract from cancer treatment by causing dosing delays or reduction, impacting the survival of those patients if they can't get their chemotherapy treatment. The symptoms range from mild to severe diarrhea, and in severe cases, you can also have secondary side effects such as bleeding, sepsis, fevers. Our model is relatively straightforward in that diarrhea is induced by treatment with 5-FU, irinotecan, or other chemotherapy in rats or mice. The duration of the model is relatively short, just 7 to 9 days, and our in-life analyses include daily weight change. We can monitor daily stool consistency, and we can even pair it with video endoscopy. So here's just some data that we generated looking at 5-FU and irinotecan-induced CID. We tested a host of increasing concentrations in both chemotherapies and applied the 5-FU once a day from day 0 to 4, or the irinotecan once a day from day 0 to 3. And what you can see is that increasing concentrations of 5-FU or irinotecan lead to a dose-dependent effect on body weight loss. And in terms of diarrhea stool consistency score, which we define as a score of 0 for a normal, well-formed fecal pellet and a score of 4 for bloody diarrhea, again, you can see a dose-dependent effect as lower doses of 5-FU and irinotecan have lower mean diarrhea scores that are generated. And with that, I'm just going to turn things over to Dr. Ben Cuffo, who's going to go over cancer supportive care therapy in a tumor treatment context.
Thanks, Jesus. So I'm going to spend the last portion of today focusing on a few models that we've been developing to capture an important aspect of development of these supportive care therapies, which is secondary safety. As every cancer supportive care therapy will be administered ultimately in the context of ongoing cancer treatment, whether it's chemo, radiation, et cetera, we have to not only consider the safety profile of the supportive care therapy itself, but also secondary safety considerations in terms of the cancer treatment regimen. So obviously we need to show for the FDA that the supportive care therapy is going to be safe and effective as monotherapy, but also safe and effective in the context of anti-cancer treatment. This meaning that the supportive care therapy will not mitigate the efficacy of the primary anti-cancer treatment, and that the supportive care therapy will not exacerbate the growth or progression of the cancer itself. So here at Biomodels, we've developed a few preclinical composite models that can co-assay the efficacy of the cancer treatment-associated therapy towards the cancer supportive care in the context of tumor growth and treatment, thus recapitulating the clinical treatment paradigm. These models enable co-evaluation of the supportive care therapy efficacy along with primary and secondary safety considerations. So we set up these models basically inducing regimen-associated toxicity and then induce the regimen-associated toxicity by the induction method that is matched to that cancer indication. And the tox-inducing cancer treatment is programmed to allow for a partial tumor response to the treatment. This gives us a window to see if the supportive care therapy would potentially exacerbate the tumor growth, either directly or indirectly via mitigating the primary tumor treatment. Or, on the other hand, it has the opportunity to enhance the primary anti-cancer treatment as well. The tumors can be seeded at subcutaneous sites or more contextually accurate orthotopic sites. And I'll show you models for each of these. And we can also utilize bioluminescent or fluorescent reporters in the tumor cells to enable quantitative longitudinal analyses of tumor burden and also quantitative metastases. So some of the key readouts we use in these models are obviously the cancer supportive care therapy efficacy in combination with the primary anti-cancer therapy. We look at tumor growth with or without the supportive care therapy, and also tumor response to treatment with or without the supportive care therapy. Additionally, we can read out tumor progression and metastases for those models that will metastasize and have the bioluminescent reporters often. We can do some mechanism of action analyses in context of the supportive care therapy and also biomarker analyses in context. So here are the two models I'm going to talk about today. One is a oral mucositis model in the context of orthotopic head and neck cancer with targeted radiotherapy. And the second is going to be a chemotherapy-induced diarrhea or GI mucositis model in the context of colon carcinoma and 5-FU chemotherapy. And we are also have additional models even more in active development that I won't talk about today. So first I'm going to focus on the oral mucositis in context. In this model, we use the mouse. We use an athymic nude mouse, an immunocompromised mouse, so that we can see human SEC25 tumors that are stably expressing luciferase, so that we can easily track tumor burden over time via in-life whole body imaging. The tumors are seated in the tongue, and these are originally derived from patient tongue. So they're in a contextually accurate site, and they're treated with mucositis-inducing tumor-targeted radiotherapy directed directly to the tumors on the tongue. So I'll show you a bit of data, but the key evaluations are going to be tumor burden over time. We follow body weight change. We score for mucositis, Craig described earlier, and the duration of ulcerative mucositis. And then we can also perform ex vivo analyses, which I'll show a few later. So the data I'm going to show is from this publication that we had the opportunity to produce in collaboration with our academic collaborators at the University of Chicago. And in this case, looking at the primary efficacy of the test supportive care therapy, we can see in this case that we're seeing protective effect following induction, mitigating the severity of the mucositis. And then in terms of the tumor efficacy in the same model, again, we're seeing that the efficacy of the targeted radiotherapy is not different at all when the supportive care therapy is administered. So this is a case where negative data can be good data. If we saw exacerbation, it might be troubling, but it's good to get after it in a preclinical phase. The FDA can and will ask for this data. Moving right along to the second model, GI mucositis, in the context of colon cancer and 5FU treatment. In this case, we're using a murine model in immune-competent animals, which allow for therapies that rely on the immune system for their mechanism of action, or a more complete immune system, I should say. The human models may be humanized in the immune system. That's an option for the human models. But in this case, we're working in a fully mouse system. In this case, we've seeded CT26 murine colon cancer cells in subcutaneous sites, and we're following tumor burden by digital caliper. The anti-tumor treatment and the induction of the chemotherapy-induced diarrhea is over the first 5 days of the study, following randomization into treatment groups around a common tumor burden. And the chemotherapy in this case is 5FU. We can follow tumor burden over time, either by IVUS imaging, or they're expressing a reporter, or by a tumor volume via digital caliper. We follow body weight change. In this case, we're using a stool consistency scoring system, which is a bit different than the mucositis scoring system, but generally just goes from completely intact stools to loose stools to overt diarrhea. And we can measure the duration of diarrhea. We often do colon weight-weight ratios to look at inflammation, and then ex vivo analyses. So I'll show you some example data from this model. In terms of the tumor volume, we can see that the 5-FU at this dose, which does induce diarrhea, and I'll show you that data in a second, induces a nice sort of middle range for tumor growth kinetics, where we can imagine that those tumor kinetics can be exacerbated or inhibited by the supportive care therapy. And on the right, we're seeing that same data showing cumulative. We can look at survival. Again, we can generate survival curves that allow for to move the dial in either direction. Body weight change can be used as well, and we can see improvements or exacerbation there as well. And then on the bottom left, you can see the stool consistency score, sort of an example where, much like mucositis, we have an induction phase followed by a resolution phase. And we're looking at this over a 12-day period where we're treating with the 5-FU or irinotecan over the first 5 days, and we see a rapid induction phase and a more slow resolution phase. And we also can assess body condition score, which is an overall clinical assessment of body condition of the animals, again, over the same time period. This is just an example of the duration of diarrhea and how we can assess the significance of duration, looking at total animal days with diarrhea versus without diarrhea, and doing chi-square analyses. You can see in this case the 5-FU is causing a very significant increase in diarrhea for these animals. And here I'm going into some of the ex vivo data that we can use to assess more mechanistic aspects and readouts from these models. So colon weight-length ratio, as expected, the 5-FU treatment is increasing the weight-length ratio of the colon of these mice. These are all day 5. We can use physidextran to assess the intestinal permeability of these mice, and you can see the 5-FU, it increases the intestinal permeability via physidextran plasma assay. We can also look at mechanistic effects on the tumor cells, looking, for instance, in this immunocompetent animal at tumor-infiltrating lymphocytes, taking the tumor and parsing out the different T cell populations. In this case, we're looking at CD8 positive T cells, slight increase in the 5-FU group in those cells, CD4 T cells, and then in Tregs, which were largely completely abolished in this model by the 5-FU. We can do gene expression analyses as well. We can look at, in this case, we're looking at mRNA levels of inflammatory factors, interferon gamma increase in IL-6 in the colons of these animals under 5-FU. We can also do protein analyses using multiplex platform. And finally, we can match this with histopathology in the colon. We can look at various factors and histopathological evaluations. In this case, we're looking on the top left at inflammation, and we can look at crypt length and crypt degeneration. And on the right, we're seeing goblet cell loss. And on the bottom, we're just seeing some example slides from this sort of analysis. So just in conclusion, the big takeaways from these sort of composite models section, novel therapies directed toward cancer supportive care will always be administered in the context of cancer and the primary anti-cancer treatment. And for this reason, the test supportive care therapy must be demonstrated as safe and effective not only as monotherapy, but also in context. Supportive care therapy must not exacerbate tumor growth or progression or mitigate the efficacy of the primary anti-cancer therapy. Here at Biomodels, we've developed composite preclinical models that capture cancer treatment-induced toxicity for radiotherapy or chemotherapy-induced oral mucositis and chemotherapy-induced diarrhea in tumor context. These models enable simultaneous preclinical assessment of these key readouts. And the models are also very useful to enable a myriad of ex vivo assays to establish mechanism of action and biomarkers, and may inform effective dose or optimized treatment schedule. And I hope to soon have the opportunity to tell you about some additional models we've been working on to capture cancer treatment-induced toxicities. And that might be good platforms to study and assess new candidate supportive care therapies. So with that, I would like to thank everybody very much for attending and for your time today and listening. We have a great team here at Biomodels, and I'd like to thank all of them as well and acknowledge them. Please, if you have any questions, I think we're a bit short on time, but we would be very happy to answer on a call or via email. So please don't hesitate to reach out and contact us. Thanks very much.
Thank you very much. We have come up to our end time. I'd like to thank our presenters for today, Dr. Gregory Ling, Dr. Jesus Mena, and Dr. Benjamin Cuffo for presenting today. I'd like to thank Biomodels for sponsoring. Most of all, I'd like to thank you for coming and spending this time with us. We're very grateful you chose to be with us and hope to see you at future CHI Web Symposia. Thank you all so much and have a great day.